Many cultures in the early ages viewed mental illness as a result of demonic possession, a form of religious punishment, or they were seen as witches. Hippocrates was one of the first to reject the supernatural explanation for mental disorders. He realized that mental disorders isn't shameful and individuals should not be held accountable for it. He focused on changing the environment of the patient or giving substances as medication. However, negative attitudes towards these individuals persisted and they were still treated poorly. In the 1600s, people with mental disorders were isolated and treated inhumanely, like being chained to walls, jailed, or kept in dungeons. In the 1700s, there was a growth of a more humanitarian view of mental disorder and the mentally ill. Protests arose over the treatment and housing conditions for these individuals. As a result, shackling was forbidden in some areas. However, these positive regulations were not widespread. In the 1800s in the US, people with mental disorders were housed with criminals and the homeless. They were left in the darkness, unclothed, without heat or bathrooms. In 1840, after witnessing the unhealthy and cruel conditions, Dorothea Dix lobbied and persuaded the U.S. government to fund 32 state psychiatric hospitals for people with mental disorders. However, improving the living conditions did not cure the patients like they expected, so there was a lot of overcrowding. In the early 1900s, an autobiographical report by Clifford Beers revealed that he received degrading and dehumanizing treatment at a mental institution in Connecticut. Due to his experience, he founded the National Mental Health Association, which was later renamed Mental Health America. This is the largest umbrella organization for mental health and illness in the United States today. In the 1930s, lobotomies and electroconvulsive therapy was being used as treatments for mental disorders, as seen in the pictures. In 1949, lithium, the first effective drug for mental illness, was introduced and widely used to treat bipolar disorder. In 1952, the first antipsychotic drug, chlorpromazine, was discovered and brought onto the market. It didn't cure patients, but it did control symptoms, and about 70% of schizophrenia patients had huge improvements with this drug. Also in 1952, the first edition of the DSM was published. With the introduction of drugs, many were released by institutions. They were sent back into society and became homeless due to inadequate housing and follow-up care. In the present day, there are lots of new medications that are successfully treating people with mental disorders. However, homelessness, incarceration, and stigmatization of the mentally ill is still an issue, in addition to lack of resources to treat people with severe mental illness. So what exactly is a mental disorder? A mental disorder is characterized by changes in thinking, emotion, or behavior that causes significant distress or impairment of functioning in social, work, or family activities. There are many different kinds of mental disorders, but our focus will be on mood disorders.
Hi, my name is Roxy. I am a senior undergraduate student at UCLA in the psychology department, and I have bipolar disorder.
There are two major categories of mood disorders. Bipolar disorder is characterized by both depression and mania, whereas major depressive disorder is characterized by at least one major depressive episode. A major depressive episode is a period of at least 2 weeks with at least 5 of the following symptoms: depressed mood, lethargy or fatigue, too much or too little sleep, feelings of worthlessness or guilt, significant weight or appetite change, decreased interest in formerly enjoyable activities, difficulty concentrating or making decisions, recurrent thoughts of death or suicide. On the other hand, manic episodes have at least 5 of the following symptoms for 2 weeks: pressured speech and increased talkativity, feelings of euphoria, involvement in high-risk behavior, irritable mood and increased goal-directed activity, inflated self-esteem or grandiosity, decreased need for sleep, or increased and unsustainable activity levels. In contrast, hypomania is less severe and does not impair functioning, and it lasts at least 4 days.
So, bipolar disorder and mental health issues in general are very prevalent in my family. My mom has depression, just unipolar depression for her, and my dad has bipolar disorder, and both of my parents struggle a lot with depression.
There is not one clean cause for mental illness, and mood disorders are not any different. It is often a mix of genetic predisposition, environmental triggers, psychological state of mind, and neurobiology that may lead a person to develop bipolar or major depressive disorder. Depression often runs in families as it is genetically inherited. Compared with the general population, first-degree relatives of depressed individuals have a nearly 3-fold increase in their risk of developing a major depressive disorder. While conducting twin studies, researchers have found that if one twin develops clinical depression, the other will do the same over 75% of the time. If the twins are raised apart, the likelihood that they both will become depressed falls to 67%. However, having a genetic makeup does not guarantee that one will develop mental illness. Rather, it predisposes the individual with an increased risk if triggered by negative life events like losing a loved one, as well as abuse of drugs and alcohol. Neurotransmitter imbalance is a known cause of bipolar and major depressive disorder. The neurotransmitters released from the presynaptic neuron are not fully received by the postsynaptic neuron. The neurotransmitter hypothesis of bipolar and major depressive disorder speculates that disruption in transporter and receptor homeostasis may underlie the pathophysiology. In general, low levels of neurotransmitters are associated with depression, while high levels are associated with mania. Notably, studies have shown that hyperglutamatergic neurotransmission in the PFC and ACC is associated with bipolar disorder. For instance, low levels of norepinephrine may cause decreases in energy or motivation as well as poor memory, while high levels may cause increases in hyperactivity and anxiety. Imbalances in serotonin are responsible for depressed mood, food cravings, sleeping problems at low levels, while agitation and restlessness at high levels. Problems with dopamine levels may lead to compulsive behavior or cravings associated with depression, anxiety or psychosis associated with mania. Emotional destabilization in mania and depression may reflect a disruption in a frontal-limbic functional connectivity. Specifically, the neural circuitry between the amygdala and the prefrontal cortex may be affected in patients with bipolar disorder. Those affected by major depressive disorder and bipolar disorder have different neurobiology that can be triggered by external circumstances compared to those not affected. Mood disorders are therefore both psychological and physiological. This is an important distinction because the general public often considers mental illness not a quote-unquote real disease. Therefore, they may have significant biases against people with mental disorders.
I have experienced some discrimination because of my bipolar disorder. Unfortunately, it has led to the ending of certain friendships, and it's affected me and my loved ones in so many ways.
Stigmas about mental illness are widely endorsed by the general public. There are 3 themes that describe misconceptions about mental illness that correspond to stigmatizing attitudes. First, there is fear and exclusion. This is the idea that people with mental disorders are dangerous, should be feared, and kept out of certain communities. This can result in social distancing, which is the desire to avoid contact with a particular group of people. Studies have shown that social distance is related to attitudes towards adults with mental illness. So those who have negative biases towards these individuals will keep their distance. Next, there is authoritarianism. This is the idea that people with mental disorders are not responsible, so life decisions should be made by others. Third is benevolence, which is the idea that people with mental illnesses are childlike and need to be cared for. Most people with mental disorders are both willing and able to work, yet their unemployment rates remain high. Reports show that about 80% of individuals receiving mental health services are unemployed. There are 4 underlying stigmas in the workplace. First, people with mental health problems lack the competence to meet the demands of work. Second, people with mental health problems are dangerous or unpredictable. Third, working is not healthy for people with a mental health problem. Fourth, providing employment for people with mental illness is an act of charity. Additionally, a nationwide study on U.S. employers revealed that almost half would rarely employ someone with a mental disorder. Even those who manage to find employment are often given menial labor. Menial jobs can be described as unskilled work that requires long hours, is low paying, and does not allow for career development. In a cross-sectional study conducted across 35 countries, discrimination against people with major depressive disorder was significantly found. Approximately 62.5% of 834 participants experienced or anticipated discrimination, while 60% stopped applying for work entirely because they anticipated discrimination. A recent study interviewed individuals with a range of mental disorders. Many of the people wanted a relationship, but revealed that the stigmas associated with mental disorders was a barrier to successful dating. They reported instances where their dates or relationships ended because they told the person about their disorder, or their partner found their medication. So having a mental disorder is a deal breaker for many people because of the associated stereotypes. Recovery for individuals with mental disorders is fostered by engaging in social roles, like having a job or being in a relationship. Clearly, the stigmas perpetuated by the public prevent these individuals to engage in healthy activities. The biases that people with mental disorder face also affect their access to healthcare. Less than 40% of individuals receive stable treatment for their illness. Additionally, there are two trends in individuals with a mental illness when pursuing healthcare. Either they never pursue treatment, or they begin treatment but don't finish it. But why is this happening? Oftentimes, the desire to avoid the public stigma causes individuals to drop out of treatments or avoid it for fear of being associated with negative stereotypes or discriminated against. Even medical students experience depression and mental illness, but few seek help. This is counterintuitive, as they should be the ones recognizing the signs and getting help, but it's stigmatized.
I really wouldn't have gotten through these last, specifically 5 or 6 years of mental health problems without a lot of support. My friends and family have been instrumental to me getting through this. I am so grateful that I've had support. If I had not, I think that it would have been a lot harder for me. Also, I have adopted many different coping mechanisms to help me manage my stress, which in turn manages my symptoms. I do art, which is actually on the wall behind here, and I've really found that to be a meditative activity for me where I can really just focus on one thing. Also, meditation itself, I do a lot of mindfulness, and really keeping a balanced lifestyle is a huge support to me. So trying to get regular sleep every night, a good amount of hours, eating well, exercising, and meditating a lot. Pretty much anything that I can do to balance myself is really helpful to me and everyone around me.
It is important to cope individually with mental disorders, but as a society, we need to work to change our own biases. The goal of educational interventions, like an educational campaign, is to present factual information about mental disorders to correct misinformation or negative beliefs. Individuals who have a better understanding of mental disorders are less likely to endorse bias and discrimination. Additionally, studies have shown that participating in educational programs on mental illness resulted in improved attitudes toward these individuals. Protest and advocacy is a formal objection to negative portrayals of people with mental disorders. These protests seek to diminish negative attitudes about mental illness. Additionally, it can provide opportunities to create a sense of solidarity for this community and bring awareness to the stigmas and discriminatory behavior that affect them. Oftentimes, the people who hold these negative attitudes have little meaningful contact with people with mental disorders. Lack of contact fosters discomfort, distrust, and fear. Research has shown that having positive, meaningful contact reduces these biases and negative beliefs. According to studies, young people use an overwhelming amount of terms with negative connotations to describe people with mental health problems, such as disturbed, psychotic, and confused. Additionally, the term bipolar exists in our lexicon as a word to describe something that rapidly or drastically changes. Generally, this adjective form of bipolar is used to imply a negative connotation. Our society as a whole needs to learn that mental illness is not automatically or inherently associated with a negative emotional state, and this assumption can cause many issues for the individual affected. Another way language plays a role in classifying individuals with mental disorders is the concept of person-first language versus identity-first language. Person-first language emphasizes the person before the disorder, and identity-first language puts the disorder first in the description. It is usually a matter of personal preference, so it is really important to ask individuals what they prefer or listen to how they identify themselves.
I am a person, and bipolar disorder is part of me, and I am not bipolar disorder.